4.2 liter per minute. It is the alveolar ventilation and it is the effective ventilation. This amount of air is coming contact with the respiratory membrane through which diffusion can take place. And for this purpose, if there is shallow rapid breathing, then the alveolar ventilation is less in comparison to slow deep breathing. When the minute ventilation remains constant, but the respiratory rate is slow, increasing the tidal volume, then this alveolar ventilation will be more. In good test, there are examples. These are very easy things, I think. Suppose when you consider this value at different rate. If this ventilation is, suppose when the rate is 10 per minute, and when the rate is suppose 60 per minute, and whenever it is 10 per minute, the tidal volume is 600 ml, and here it is 100 ml. We can change this for the sake of understanding. 30 per minute, and it is 200 ml per minute. Negative value may appear. Now tidal volume this, and alveolar ventilation. Alveolar ventilation in this case is 12 multiplied by 600 minus 150. এটা কত হয়? 4500 ml, 4.5 liter per minute, and in this case it is 30 multiplied by 200 minus 150. 1500 ml, that is 1.5 liter per minute. Because of the dead space, shallow rapid breathing is less effective than the slow deep breathing. Whenever, in case of animals like dogs that are deficient in the sweat gland, during the hot days they have panting, shallow rapid respiration in dogs in these summer days, and in that case there is little increase in the alveolar ventilation because there is no ventilatory problem. The idea is to eliminate as amount of heat in the form of lost water vapor, and there is an effective process. When the ambient temperature or surrounding temperature is almost equal or even more than the core body temperature, then only one way remains to lose heat is the evaporation by the latent heat. Because the other ways of heat loss is negative, body gaining heat from outside. Only one way to lose heat in this way. So in these hot humid days, then there is severe sweating when we are exposed to the outside or exercise outside, huge sweating. So that, and So this is the principle. There is a rapid shallow breathing. As there is this 1.5 means it is much less than 4.5. 4.5. And how to measure this dead space? Anatomical dead space or total dead space that is equal in health. And it is important is a single breath nitrogen curve. Single breath nitrogen curve. It is important for the examination. And to some extent, some conception regarding the respiratory physiology. Single breath nitrogen test. Single breath nitrogen test. Single breath nitrogen test. Then with this curve, it is nitrogen concentration, lung volume. If from mid inspiration, if an individual takes pure oxygen up to the maximum level, from mid inspiration, we are taking pure oxygen up to the total lung capacity, and then exhale slowly. Then, and near the mouth, a rapid nitrogen meter is measuring the concentration, percentage of nitrogen that is coming out through the mouth continuously, and it is plotted single breath nitrogen curve. So initial part, suppose the lung volume total is the total lung capacity. Yes. So the initial part, at the initial part there is no nitrogen. If we take pure oxygen, then begin to exhale. Initial part is coming from the dead space. It is occupied with oxygen, and initial part does not contain any nitrogen. Concentration is 0. But after that, there is some mixing in the interface between the dead space and the alveoli, and there is gradual increase in the nitrogen concentration. And then there is a horizontal plateau part, phase 3. Phases are 1, 2, 3. It will be given in the examination. Single breath nitrogen test. What is the significance? As a short note. So this initial part does not contain any nitrogen, and then part 2, phase 2, there is mixing between the dead space gas and alveolar gas, and it is gradually increasing. And in the phase 3, it is almost horizontal to the abscissa of plateau phase. Slight upward slope. And then there is abrupt increase. So anatomical dead space is the phase 1 and half of this. And up to this, it is the equal anatomical dead space. Anatomical dead space. Yeah. Anatomical dead space. and in this horizontal of the plateau phase is due to, that is from the alveoli. Average concentration coming from all the alveoli. Everywhere in the individual is in the sitting or erect position. And up to this, it is almost horizontal. Then there is abrupt increase in nitrogen concentration. And this point is called the closing volume. Up to this, it is the closing volume. It is this closing volume. Closing volume. Beyond this is the residual volume. It is entrapped residual volume. This is this residual volume. It cannot come out. And this point is the closing volume, and it indicates there is airways in the dependent part of the lungs begin to close. Airways in the dependent part of the lung begin to close. And it's called closing volume. And it is a measure of very peripheral airways. Condition of the very peripheral airways, closing volume. Due to less transmural pressure, it is occluded. Closing volume. Now, question is that how it is possible? Because this ventilation per unit lung volume in an erect individual is different in different position of the lung. It is more in the dependent portion and less in the non-dependent upper part of the lung. Yeah. Interpleural pressure is less negative at the base of the lung. Interpleural pressure is less negative and more negative above. Suppose in the basal position, at that position, interpleural pressure is minus 2.5 centimeter of water. And at this it is minus six centimeter of water. It is less negative. This value in the text, it may differ from whatever, but the concept, we have to consider the concept. Now, what occurs? Suppose it is minus 10 centimeter water, I can remember this type of things. Now, in this position, and it is in the position after the normal expiration, that is at the level of the functional residual capacity. And due to less transmural pressure, and it is per unit lung volume, it is at that normally, and it is more dilated. Transmural means inside and outside. It is plus 10, so it is more dilated, and it is less dilated. Per unit volume, you can consider. Now, whenever there is inspiration, then negativity will increase equally in this side. Suppose when it is minus 6.5 and it is minus 14 in this case. Normally it is stressed and it is maximum, it is the more towards its maximum value. So it will expand to a much less extent. But it will expand to a great extent. So more oxygen will enter, and so in this case dilution of nitrogen is less in the erect individual. Dilution of nitrogen is less, and here there is more dilution, and in this phase it is coming from everywhere. There is slight upward trend, but when at that position during forced expiration and it becomes the airways or alveolus do collapse, so that in preference this air is coming out, and as it was more dilated initially, it taken less amount of blood because its compliance is to some extent low. So its nitrogen is less diluted than this. If you consider the dilution, it is in this position, and so its nitrogen concentration is more, and it is coming late. So it indicates that the dependent part has been closed and air is coming preferably from the non-dependent part of the lung. So it indicates that is the airways in the or alveoli in the dependent part of the lung beginning to close. Closing volume. It is an important test, at least theoretically it is not done here, and it is at the peripheral airways, test of the peripheral airways. Yeah, closing volume. So this closing volume you can call it is this part. Above the residual volume. And roughly 5% of the vital capacity. You have started from this point, FRC, and up to this level. So it is up to this level is the vital capacity. Normally it is 5% of the vital capacity. % of the vital capacity. বোঝা গেছে? বইটা একটু খুললে দেখবে একদম সহজ মনে হবে, কিছুই নেই এতে। And some text they mention that closing volume plus this, it is the closing capacity. And when there is airways disease as in emphysema or so, and in that case the closing volume will increase. In this percentage will increase, and in that case this, suppose it is in this position. When the transmural pressure is less, elasticity of the lungs is reduced. Initially the transmural pressure is less, or the airways are already narrow, so it occurs early. It occurs late in the vital capacity in normal individuals, but it occurs early in the plateau phase whenever there is diseases of the airways, chronic obstructive pulmonary disease also. Now this, by means of this anatomical dead space and also the total or physiological dead space, can be measured by Bohr's equation. Besides this, by Bohr's equation, you can measure this. Bohr's. equation. Bode's equation. Bode's equation. Bode's equation. You can have this Bode's equation. Carbon dioxide partial pressure. Carbon dioxide partial pressure of this alveoli and the expired air, you can, and tidal volume, you can calculate it. Bode's equation. The basic concept is that, of this equation is that, suppose I am inhaling and then exhaling. So, initial part of the exhaled air will come from the dead space. Its concentration of carbon dioxide is minimal. I am inspiring, the outside contains negligible carbon dioxide, and then exhale. So, the expired air contain a mixture of the dead space air, and the later part of the ventilation is coming from the alveolar ventilation. So, you can replace the concentration by partial pressure. So, concentration and partial pressure, they are related. It is proportional. Proportional. And related concentration, that is the fraction. Pb minus pH2 multiplied by the fraction of carbon dioxide in anywhere it is possible. So, we can replace it with concentration is partial pressure. So, you can have this concept. In case of expired air is equal to dead space air plus alveolar air. It is the basic concept. When after inspiration you are expiring, initial part of the expiratory volume was occupied the dead space. The latter part coming from the dead space air. So, and if you take the partial pressure, that is the PeCO2 into tidal volume is equal to dead space air, that is this PiO2 into dead space air, PiCO2 plus PaCO2 into, there is the difference between the alveolar ventilation, tidal volume minus dead space. Yeah. Now, in the inspired air, carbon dioxide concentration and partial pressure is negligible. So, you can ignore this term. So, PeCO2 is equal to this. So, dead space volume rearranging, you get tidal volume into 1 minus PCO2 and PaCO2. It is the what's equation. And when we are using capital A, then it indicates anatomical dead space. Then it indicates anatomical dead space. Anatomical dead space. P capital A. Then if you put the normal values, you have the value you want, dead space. So if you take the tidal volume is 500 ml into 1 minus, it is 28 millimeter of mercury and it is 40 millimeter of mercury. By 150 ml. And when you use the term P capital A, then it measures the anatomical dead space. Anatomical dead space. Anatomical. And it is measured from the alveolar gas. How to collect the alveolar gas? It is the terminal part of expired volume. It is the terminal part of the expired volume. Terminal part. কারণ আমরা যখন শ্বাস ছাড়ছি, initially there is some mixing. Initially some mixing with the dead space here, but very terminal part. There is a 10 ml of the expiration. Last expiration must be coming from the alveoli. And it is independent from which area it is coming, independent of which. So it is a measure of average ventilation, and from that you can have the concentration and the partial pressure down, and when it is using it, it is anatomical dead space. And when in this formula it is replaced by P small a CO2. Small a CO2, PA means arterial CO2. Arterial CO2. And what it indicates? It is the effective volume where there is equilibrium. Wherever there is equilibrium. Yeah, equilibrium. So in normal individual, P small a is equal to P capital A. But in the diseased condition, it may not be. Some alveoli, this perfusion may be low. So there is overventilation, or in some cases there is no perfusion at all. So in that case, this P capital A is different from the P small a. Yeah. So when you are using this value, then it is means the effective ventilation. Effective ventilation. So when it is PaCO2 means whenever there is equilibrium, then it is PaCO2. In some cases it is possible that some part of the alveoli, some part of them may not be perfused. Suppose a basic concept, suppose you take one alveoli like this, and it has adequate perfusion. So blood is entering from this and it is taking out air from this. It is a normal, perfectly normal alveolus, and here it is the PaCO2 and it is 40 millimeter of mercury. And at the very beginning, suppose it is the PaCO2, that is the mixed venous blood, and it is 46 millimeter of mercury. And when it is leaving, normally it attains the equilibrium early, and when it is leaving, it is 40 millimeter of mercury. 40 millimeter of mercury. And it is normal, it is a normal condition. It is a normal condition. Now you suppose another condition in which part is perfused, part is not. This part is perfused. And this part is not. This part is not. There is no perfusion. And here it will attain the value. If it is 40 inside, it will 40 outside. So in that case, the PA, and in this case also same. But this alveolar, when you are considering the alveoli, and in that case there is no perfusion. So PaCO2 value is less than, suppose it is 10. So when you considering the PA value total, it is less than 40. 40. So in that case, the PA is less than this value. Here it is the ideal condition. There is the red color indicates the perfusion, and there is exchange. Initially, blood is coming with partial pressure of carbon dioxide, 46 millimeter of mercury, mixed venous blood, and it is coming out, attaining the equilibrium. Here, equilibrium. It is normal, but in this case, you consider there is a communicating alveoli, but it has no perfusion. And as there is no perfusion, less carbon dioxide will be present here. So this part will be, so it's in this case its PA is less than this value. So total dead space, when you measure total, then it is more than normal value. By the same formula you can apply. So in this case it is different. Alveolar partial pressure is different than this case. So in health they are equal. P capital A CO2 is P small s CO2. But whenever there is some alveoli, there is overventilated or less perfusion is there, then there is the thing changes. Yeah. Changes. So total ventilation is different from that of the ideal situation. So by means of Bohr's equation, you can calculate both the anatomical dead space and the total dead space. Ventilation and perfusion is in erect individual is different in different level. In the course of discussion of the closing volume, we discussed there is the ventilation per unit lung volume is more in the dependent part than in the than in the non-dependent part. And how it is so? If you go in further deep, it is mostly due to the weight of the lungs. Besides this, there are other factors also. If you consider the case of these lungs, one lung if you consider. At the basal part, initially it is minus 2.5 centimeter of water, and at the top part it is minus 10 centimeter of water. And if you draw the compliance curve, lung volume, if you consider, it is the centimeter interpleural pressure, interpleural pressure, ppl. So that whenever it is operating at this level, its slope is more than in case when it is at that level. Slope is less. Slope is less. The same thing we discussed. So initially its percentage of maximum, it is close to the percentage of its maximum, 10%, close to 10%. Suppose it is 90% or so. So initially it is dilated. So per unit lung volume, it is initially dilated. But in this case, it is initially lower. And when the same negative pressure is applied, expansion, that is the interval pressure falls to in the same value, same negativity, minus x and minus x. And in that case, it has already in this part, so it is relatively stiff, so it will expand to a small extent. But it is extend to a much greater extent. So per unit lung volume, there is the ventilation is more in the dependent part. But when the individual is supine, then in linear sense, it disappears. And it is due to the weight of the lungs, mainly due to the weight of these lungs. Less negativity is due to weight of the lungs. Whenever some weight is pressed, then pressure is lower, less negative at that side. In physics text, you have seen, then there is a cylinder and there are side openings, and water is coming at more distance from the base. It is due to height that is operating. Clear? You can remember your school days in the physics. There was an experiment, basic experiment, that water is present, and if there is an aperture and its flow is in, and at that part it is going longer, because in this case this pressure is dependent part is the more due to additional fluid. Barometric pressure plus this height and barometric pressure plus this height, so it is much more, and the water is coming to more distance. You can remember in your physics text. And similar thing is applicable to basal part of the lung. Due to this gravity, then it is less negative. Upper part is more negative. More negative means transmural pressure is more. Transmural pressure means pressure within the alveoli, and when it is in communication with the atmosphere, you take the value as 0. 0 minus 10 is equal to plus 10. So it will dilate initially. So its capacity, and it is operating in the compliance line that is relatively stiff. So it will accommodate little more air, but it is operating in that part that is where it is more compliant. Additional volume is taken. So the dependent part of the lung, per unit lung tissue, will have more ventilation. Now in case of perfusion in an erect individual, the blood pressure, average blood pressure of the pulmonary artery, you can have this concept, average pressure 14 to 15 millimeter of mercury also. So at the top of the lung, it is lower, and some phases of respiration. Land is God-made and it is the man-made. So man-made product is always inferior to God-made product, whatever it may be. So you think that perfusion at the top of the lung is relatively low due to gravity. Gravity. You can easily understand because your veins are prominent here, in the dependent part prominent here. And if you raise your hand, you see that these veins will ultimately collapse at a particular level. If you take in this position, the veins will engorge. And if you gradually raise it, that at one level it disappears, and when it is above it, it is completely collapsed. Completely collapses. So that gravity is operating similarly in the arterial walls also, arterial lumen also, because there is no air, it is full only with blood. So in the upper part, there is this reduction in the pressure, systolic pressure, diastolic pressure, and the mean pressure. And the basal part of the lung, that is increased. In the apical part, it is possible during phases of respiration, there is almost no blood flow. No blood flow. It is possible. During the expiratory phase, there may be no blood flow because the pulmonary arterial pressure is close to capillary pressure, 10 millimeter of mercury or so. It is lower at that side. And in that case, during expiration, the alveolar pressure may be such that it goes above it and there is no circulation. But during inspiration, there may be some flow. And the middle part of the lung, it is that in some phases of respiration, this alveolar pressure is more than pulmonary venous pressure. Arterial pressure and capillary pressure has increased. But as the alveoli are compressing the veins, there is no flow. And very dependent part, everywhere there is the alveolar pressure. Everywhere this alveolar pressure is lower than that of the pulmonary arterial pressure and the venous pressure. So in all phases there is some ventilation. There is some perfusion. And in this way, it is given in different texts in this. So that due to this height, there is a pressure increases in the systemic and also in the pulmonary. 1 centimeter height is equal to, then you will find out what is the millimeter of mercury. 0.77 millimeter of mercury in this every centimeter. Every centimeter of height is equivalent to 0.77 millimeter of mercury. এটা কি করে জানা গেল? বইয়ে এটা দেওয়া আছে। কারণ এটা বইয়ে তুমি যখন পড়বে তখন যারা লিখেছে বই তারা মনে করছে যারা রিডার আছে তারা এগুলো সমস্ত জানে স্কুলে। জন্য তোমাদের স্কুলের যে বইগুলো সেগুলো ফেলে দিলে চলবে না, সেগুলো এখন বার করতে হবে। যে কদিন ফিজিওলজিতে আছে, বুঝতে পেরেছো তো? যে কদিন এই সমস্ত কদর্য লোকের সাক্ষাৎকার হয় সেই কয়দিন বইগুলো একটুখানি খুলে বার করতে হবে, তাহলে তুমি বুঝতে পারবে। 1 centimeter is equal to 10 millimeter and divided by the density of mercury 13.6 becomes 0.77. Suppose I am in the red position, from this heart level, suppose it is 50 centimeter. So 50 multiplied by 0.77 plus the mean blood pressure, and at that level that will be the mean blood pressure. So from the heart level it is 30 centimeter. So it is the mean blood pressure minus 30 into 0.77. Now, in this case, there is ventilation do increase from the top to the bottom, and blood flow or the blood pressure will increase from top to bottom. But in case of, there is this difference is more applicable in case of perfusion than in the ventilation. So in good text, there are some simple figures that can indicate it. Rib number, ventilation, alveolar ventilation per unit lung tissue, and perfusion in the same direction. In case of ventilation, suppose at the 4th level or so, and it is this ventilation, but this perfusion is more steep. It is the perfusion, it is the ventilation, and it is the perfusion. So at this point it is equal, it is the same point, it is 1, ventilation and perfusion, that is normal value, or if you take it is normal value as 1 in this figure, because there is this same. Now when you go to the top of this, it is the top to bottom, and here the perfusion was more than ventilation. So ventilation by perfusion is less than this value. Excuse me, ventilation perfusion. And at this bottom, it is different. At this bottom, it is different. Perfusion ratio. From the top to bottom, if you take in this way, then it becomes clear. Ventilation perfusion ratio, that is the ventilation increases to the bottom, but its slope is lower than that of the perfusion. So at the top level, ventilation perfusion ratio is more. So in this case, this partial pressure of oxygen on the alveoli will be more, and within the oxygenation of the blood will be more at that place. And it is the reason of predilection of tuberculosis in the apex of the lung. And by this, another important graph is that it is our last topic. Suppose it is PCO2 and PO2, alveolar or arterial if you consider. And suppose whenever this is ventilation and perfusion ratio you are considering, and in that case it is the blood that is coming. Ventilation, perfusion is zero at that point. And so this within this concentration or the partial pressure is equal to mixed venous blood. Mixed venous blood. That is the PO2. It is 40 millimeter of mercury. 40 millimeter of mercury. And PCO2 is 46 millimeter of mercury. 40 and 46. So the blood that is coming, it will take this. For theoretical thinking, you are considering that is the alveoli is not collapsing. Yeah. And in that case, it will be 40 millimeter of mercury PaO2 and 46 millimeter of mercury PCO2. In normal individual, normally you are taking this value, this from this graph, and they are patent. Both are patent and effective. Blood is coming out and air is coming out. Air. And here there is normal value. There is equilibration. And whenever there is equilibration, then it is 100. It is 100, this point. It is 100. And it is 40. It is 40. It is normal value. Ventilation perfusion ratio is normal. What is the normal value? Ventilation ratio, we discussed, it is 4.2 liter per minute. You take the perfusion, total perfusion of the whole lung, 5.5 liter per minute. It is 0.8 or so. And here this value is 140. And where there is no perfusion, where ventilation is occurring, but there is no perfusion. It is blocked. And so air will come into the alveoli and it will equilibrate, and it will be equal to that of the inspired air, where PCO2 is 0 and PO2 is 150. So in this case, it is 150, 0. This point. This is the point. Here this ventilation and perfusion ratio is infinity. Because there is no perfusion, there is a block, infinity. So it will attain this value. So whatever may be the condition, in whatever may be the disease, it will follow. There is this from this point, to this point. In this direction and in this direction. And here there is no ventilation, and here there is no perfusion. It is the extreme conditions. But in disease case, it will remain within this point. And it is a unique diagram of having concept regarding this ventilation, perfusion in different sites of the lung, and also these diseases. In disease, whatever may be the fluctuation in diseases. In most of the diseases, there is some disruption of this ventilation ratios. বোঝা গেল? যতটুকু আমার জ্ঞান বুদ্ধিতে কুলালো আমি বললাম, তোমরা তোমাদের উন্নত বুদ্ধিতে আরো ভালো করে শিখে নেবে, অন্য বই থেকে পড়ে নেবে। বুঝতে পেরেছো? দেখবে যত পড়বে তত সহজ মনে হবে, এবং তখন আমাদের প্রতি তত অশ্রদ্ধার বৃদ্ধি পাবে, এবং এইভাবেই তোমার এগিয়ে চলেছে আমাদের বছরগুলো, যে কদিন শেষ না হয়। তাহলে আজকে এই অবধি শেষ। ধন্যবাদ।
In a outpatient department of surgery, a young aged about 17 years present with a lump in the inguinal region, which is increased on coughing, and on lying down it disappears. What is the probable diagnosis? Very good. খুব সুন্দর বলেছে, আমিও বলতে পারতাম না। হ্যাঁ, সো ইনগুইনাল হার্নিয়া, বাট টার্গেট কিন্তু ওখানে নয়, ওটাতে বড় জোর 1 নম্বর। এরপরে দেবে describe the boundaries of the inguinal canal. 2, what are the contents of the inguinal canal? 2, Number 3, what are the defense mechanism of the inguinal canal? 4 আরেকটা নম্বর আরেকটা কিছু দিয়ে 10 নম্বরের কোশ্চেন হবে। তো এইভাবে কোশ্চেন হবে। তাহলে টুডে now already you know, now question is that practically why you, he, she, whatever may be, do not develop inguinal hernia. I am not developing, but some persons are developing, which makes us immune to this hernia, that we are not developing hernia. Normally there is an deficiency, a canal, there is an aperture, superficial inguinal ring, deep inguinal ring, so there is an every chance of developing inguinal hernia. But why we are not developing? Because of the presence of the defense mechanism of the inguinal canal. What is the defense mechanism of the inguinal canal? Number 1, boundary. You must know, just recapitulate 1 minute for the boundary. Anteriorly, there is an throughout the length external oblique aponeurosis, and in the lateral part, in addition, there is internal oblique. Roof is formed by the arched fibers of the internal oblique and transversus abdominis. And posteriorly, there is an fossa transversalis throughout the length, and in medial part, conjoint tendon and reflected part of the inguinal ligament. And flowed is by the inguinal canal. You look one thing, so there is an potential weakness in the two part. There, I mean, last year age bolchi. There is an potential weakness in the two part. If suppose there is an paper, if there is an hole, this is the weak part of the paper, right? If there is a গর্ত থাকে যদি কোনো একটা পেপার বা কাপড়ে, দেখবে ওখান থেকে ছিঁড়ে যায়। তোমাদের গেঞ্জিতে যদি ফুটো হয়, দেখবে ওইখান থেকেই ছিঁড়ে যাচ্ছে, ওই জায়গাটা দিয়েই কিছু দুই চাপ মারে ওখান দিয়ে বেরিয়ে যাবে। So this is the weak part. So what are the two weak part? Deep inguinal ring and superficial inguinal ring. দুটো ফুটো মত জায়গা রয়েছে। So deep inguinal ring in the fossa transversalis and superficial inguinal ring in the just above the pubic crest. Now look, if there is a weakness, there is a chance of developing hernia, but we are not, because look again nature or almighty or God, whatever you might call. So look, the anterior wall, deep inguinal ring is situated in which wall? Which wall of the inguinal canal? Anterior, roof, posterior, deep inguinal ring. Fossa transversalis কোন ওয়ালে থাকছে? What is deep inguinal ring? It is a gap in the fossa transversalis. So deep inguinal ring situated in the posterior wall, and superficial inguinal ring is situated in the anterior wall, because it is a gap in the external oblique. External oblique forms the in the anterior wall, right? So there is a posterior wall, there is a gap, so intestine try to bulge out, but it is prevented by the anterior wall. How? Look, throughout the inguinal canal, this is the external oblique aponeurosis, but in the lateral part, where there is a deficiency, where there is a weakness, nature gives, in addition to the, what is this? What am I writing? A drawing? Fibers of কোন ফাইবার রাখলাম? anterior wall এর lateral third এ, internal oblique. So দেখো, এই জায়গাটায় কোনো ডেফিসিয়েন্সি নেই, কোনো উইকনেস নেই, নেচার শুধু এক্সটার্নাল দিয়েছে। আর এই জায়গাটায় উইকনেস, নেচার এখানে ইন্টারনাল অবলিক দিয়ে রেখেছে, সো দ্যাট ইট ক্যানট গো আউট। সিমিলারলি সুপারফিশিয়াল ইঙ্গুইনাল রিং কোথায় রয়েছে? অ্যান্টেরিয়র ওয়াল আর পস্টেরিয়র ওয়াল? অ্যান্টেরিয়র ওয়াল। তাহলে কাকে স্ট্রেংথ করতে হবে? পস্টেরিয়র ওয়ালকে। পস্টেরিয়র ওয়ালকে নেচার কি দিয়েছে এখানে পেছনে? কনজয়েন্ট টেন্ডন, conjoint tendon and reflected part of the inguinal ligament. So, whenever there is a deficiency in the posterior wall, strengthening comes in the anterior wall. When there is a weakness in the anterior wall, strengthening comes in the posterior wall. বুঝতে পেরেছো? কেমন? হ্যাঁ, ক্লিয়ার? যেই অ্যান্টেরিয়র ওয়ালে পস্টেরিয়র ওয়ালে ডেফিসিয়েন্সি, অ্যান্টেরিয়র ওয়ালটা স্ট্রং করে দিয়েছে, কারণ পস্টেরিয়র ওয়ালতে কিছু করার নেই, গ্যাপ রাখতেই হবে। ইট মাস্ট বি দেয়ার ইজ এন গ্যাপ। সো whenever try to pushing something coming out, anterior wall preventing it. In the posterior wall there is an, in the anterior wall there is a gap, posterior wall there is a strengthening by conjoint tendon reflected part. দেখো বন্ধ হয়ে গেল। This is the conjoint tendon and reflected part, and only শুধু মিডিয়াল পার্টই দিয়েছে। কেমন? দুটো ডেফিসিয়েন্সি, দুটো স্ট্রেংথেনিং। তাহলে কম্পেনসেটরি স্ট্রেংথেনিং অফ দ্য উইক পয়েন্টস কি লিখবো? এটা তো আমি জাস্ট হেডলাইন লিখলাম। নাম্বার 1, there is a weakness in the posterior wall at the deep inguinal ring, which is compensated by the internal oblique fibers in the anterior wall. And in the anterior wall, there is a weakness in the superficial inguinal ring, which is compensated in the posterior wall by A, conjoint tendon, number 2, B, reflected part of the inguinal ligament. এরকম ভাবে লিখবে, গল্প লিখবে না, তাহলে আমাদের পড়তে সুবিধা হয়। আচ্ছা গেল, এরপরে এটা গেল একটা 1 নম্বর। এবার আমি করছি, তাহলে আমাদের হার্নিয়া হয় না কেন? নাম্বার 1, obliquity of the inguinal canal. Oblique. If the inguinal canal is straight, easily there is an hernia. But oblique, ঝামেলা হচ্ছে। In newborn, ভালো করে শোনো, inguinal canal is straight. Gradually, when the baby develops walking, then the inguinal canal become oblique. So, in the infant, there is a chance of developing of the indirect or direct inguinal hernia. But luckily, they are not, because their muscles are well strengthened in comparison to the age. So, first defensive factor is the obliquity of the inguinal canal. Number 2, flap valve mechanism. Flap valve কি? এইটা। কোন জিনিস যদি ফ্ল্যাপের মতো এরকম করে আটকায়, তাকে আমরা বলি ফ্ল্যাপ ভালভ। ফ্ল্যাপ ভালভ মেকানিজম। তাহলে কি হয়? Whenever there is an increased pressure in the abdominal wall, I repeat, when there is an increased pressure in the abdominal wall, there is a chance of hernia. But when then brain know there is a chance of hernia, it orders the muscles of the anterior wall and the muscles, the internal oblique and transverse oblique forming the conjoint tendon to contract, so that posterior wall and anterior wall comes close together. There is a gap. This is the inguinal canal. Look, this is the inguinal canal. This gap, because there is a gap in the anterior and posterior wall. Now it is anatomical position. When there is an increased abdominal pressure, posterior wall comes forward and brain orders external oblique, you do action, it comes down backwards, so that two walls completely closes the inguinal canal. So there is a no space in the inguinal canal, so nothing goes inside. No chance of hernia. Very important. এটাকে আমরা বলছি ফ্ল্যাপ ভালভ মেকানিজম। নেক্সট হচ্ছে স্লিট ভালভ মেকানিজম। When there is an, in the superficial inguinal ring is like that. When there is an increased pressure, then external oblique contracts. There are two things happen. When it contracts, it causes flap valve mechanism, so that it completely closes the inguinal canal. Number two, when it contracts, the two crusts come close together. এরকম হয়ে যায়, এরকম ছিল এই। This is the superficial inguinal ring, this is the upper crust, this is the lower crust, this is the crest of pubis. When there is a chance of hernia, increase abdominal pressure, these two crusts come close together. 8. Slit valve mechanism. Slit মানে একদম সরু করে দেয় superior crustকে, so nothing can come out. সেটাকে বলছি slit valve mechanism. Shutter mechanism. Shutter, দোকান বন্ধ করে shutter। যখনই there is a chance of hernia, internal oblique and transversus abdominis contracts and it comes out as a shutter to close to the inguinal ligament, উপর থেকে close করে দেয়, roof comes to the floor. Flap valve কি হয়েছিল? What happens in the flap valve? Anterior wall and posterior wall comes together. In the shutter mechanism, internal oblique and transversus abdominis now contracts. It is the roof. By this contraction, internal oblique comes to touch the inguinal ligament. So again, inguinal canal is obliterated. So this is known as the shutter mechanism. Ball valve mechanism সবাই জানো। When there is a chance of internal hernia, the genital branch of the genitofemoral nerve contracts. That's mean a genitofemoral branch stimulates the cremaster muscle, and cremaster muscle pulls the testis in the superficial inguinal ring. Cremaster testis, due to contraction of the cremaster muscle, the testis comes up and block the superficial inguinal ring. কি হচ্ছে? This is the superficial inguinal ring, this is the scrotum, and this is the testis. When there is a chance of inguinal hernia, increased abdominal pressure, the cremaster muscle this is the cremaster muscle, it contracts and testis pulls upwards and completely occlude the superficial inguinal ring. This is known as the ball valve mechanism. Like a ball, it occludes the valve, it occludes the superficial inguinal ring. So it is known as the ball valve mechanism. And last to bolei diyechi, compensatory strengthening. So these are happening in our body so that we are not developing inguinal hernia, whether it is a direct or a indirect. Clear? Obliquity of the inguinal canal. Number 2, flap valve mechanism. Number 3, slit valve mechanism. Number 4, shutter mechanism. Number 4, ball valve mechanism. Number 5, competency strengthening of the weak points. So খুব often it comes in the oral, and this is known as the defense mechanism of the inguinal canal. It is known as the defense mechanism of the inguinal canal. Now, usually, which is a common hernia, inguinal or femoral? Obviously, inguinal hernia is a commonest hernia. Which hernia? The femoral hernia. I am now talking about the bhalo kore shono. I am talking about the femoral hernia. Femoral hernia is common in male or a female? Female. Femoral hernia is a common in female due to femoral canal ta female er boro and blood vessels guli khub shoru hoy. Come on, what is femoral hernia kotha diye hoy? তোমাদের ফিমোরাল শীথ মনে আছে? এই তো ফিমোরাল শীথ, ফিমোরাল আর্টারি, ফিমোরাল ভেন, আর এই জায়গাটা হচ্ছে লুজ ইরেগুলার টিস্যু এবং একটা লিম্ফ নোড থাকে, লিম্ফ নোড বা ক্রকেট, and mouth of this compartment is called the femoral ring. Femoral hernia occurs through this canal. Due to wider pelvis, the diameter of this ring is very large, plus these vessels are very narrow in comparison to male. In female, so the diameter of the femoral ring is very large, so that femoral hernia is common in female. এবার ঘুরিয়ে যদি বলি, which hernia is common in female, femoral or inguinal? No, inguinal hernia is common in female. Even in female, inguinal hernia is common, but in femoral hernia is more common in female. জিনিসটা বুঝতে পারছো? ফিমেলদেরও যদি হার্নিয়া হয়, 10 জন ফিমেলের যদি হার্নিয়া হয়, দেখা যাবে 8টা হার্নিয়া ইঙ্গুনাল আর 2টো ফিমোরাল। এরপরে যদি দেখা যায় আমি 10টা শুধু ফিমোরাল হার্নিয়া নিলাম, 10টা শুধু ফিমোরাল হার্নিয়া, তখন দেখা যাবে 8টা ফিমেলের হয়েছে, 2টো মেলের হয়েছে। তো দুটো কিন্তু সম্পূর্ণ ডিফারেন্স। ইঙ্গুনাল হার্নিয়া is common, লিখে নাও, is both in male and female. Inguinal hernia is the common hernia, commonest hernia in both male and female. যে মেল হোক ফিমেল হোক, ইঙ্গুনাল হার্নিয়াটা কমন। বাট in femoral hernia, females are more affected than male. যদি ফিমোরাল হার্নিয়া নাও তাহলে শুধু ফিমেলদের বেশি হবে, কিন্তু টোটাল হার্নিয়াতে যে ছেলে হোক বা মেয়েই হোক, ইঙ্গুনাল হার্নিয়াই কম। এটা ক্লিয়ার করে নাও। ফিমোরাল হার্নিয়া হয়েছে বলেই মেয়েদের হয়েছে, ছেলেদের হবে না তা নয়, আর ইঙ্গুনাল হার্নিয়া মানেই ফিমেলদের তা নয়। সুতরাং সেইটা আমি ক্লিয়ার করলাম। নেক্সট হচ্ছে যেটা অনেক সময় পরীক্ষায় দেয়, এটা নিজেরাই পারবে, সেটা হচ্ছে হোয়াট আর দ্য coverings of the hernial sac. What is the difference between direct and indirect বলে দিয়েছি। Indirect hernia occurs through the deep inguinal ring and which is lateral to the inferior epigastric artery, and direct hernia occurs through the Hasselbeck triangle. What is Hasselbeck triangle? A peritoneal triangle which is bounded by the lateral border of the rectus abdominis, inferior epigastric artery, and the inguinal ligament. This is the inguinal terminal and this is the deep ring. So, indirect hernia occurs lateral to the inferior epigastric artery. Direct hernia occurs through the medial to the inferior epigastric artery through the Hasselbeck triangle. This is the Hasselbeck triangle. এরপরে এখান দিয়ে যদি একটা হার্নিয়া occur in the deep ring, again আরেকটা বলা হয়নি, this is direct hernia again divided into medial variety and lateral variety by obliterated umbilical artery. This Hasselbeck triangle again divided into medial part and a lateral part, we call supravesical part and medial inguinal part. Into আমরা অতঝাম মিডিয়াল পার্ট এন্ড ল্যাটারাল পার্ট। যদি এখান দিয়ে হয় ল্যাটারাল ডাইরেক্ট হার্নিয়া, যদি এখান দিয়ে হয় মিডিয়াল ডাইরেক্ট হার্নিয়া, ল্যাটারাল ডাইরেক্ট হার্নিয়া এন্ড মিডিয়াল ডাইরেক্ট হার্নিয়া, রাইট? এরপরে যেটা দেয় কভারিংস অফ দ্য ইঙ্গুনাল হার্নিয়া, নিজেরাই পারবে, ইউ ক্যান ডু ইয়োরসেলফ। আমরা জানি হোয়াট আর দ্য লেয়ার্স অফ দ্য skin. This is the skin. This is the superficial fascia. Then external oblique. What are the layers of the anterior abdominal wall? This is the layers of the skin. এইখানটা হচ্ছে স্ক্রোটাম রয়েছে। আচ্ছা শোনো, এটা ভালো করে দেখো। So it is the anterior abdominal wall. What are the layer? Skin, fascia of Camper, fascia of Scarpa, then external oblique aponeurosis. External oblique muscle, which is going to be aponeurosis. This is the internal oblique aponeurosis. This is the transversus abdominis. The blue is the fascia transversalis. This is the extraperitoneal tissue. Extraperitoneal tissue, and this is the peritoneum layer. Normally ki hoy, when testis descends, testis gets a covering of each of the layer. tar age boli nei eta scrotum, skin ta ekhane eshe skin hoye gelo, skin of the scrotum, and fascia of Scarpa, ভালো করে শোনো, fascia of Camper, which is present in the abdominal wall, when descends down in the scrotum, it changes its character and smooth muscle is present. ওই জায়গাটায় স্মুথ মাসল রয়ে গেল। যে ফাইব্রাস টিস্যু ছিল, fascia of Camper and fascia of Scarpa, they become joined together and replaced by a muscle tissue. And this muscle we call dartos, very important muscle, dartos muscle, which is under sympathetic control. We cannot control ourselves. It is controlled by sympathetic. When there is an temperature variation, when there is an stimulation, only then the dartos contracts. তাহলে এটা গেল dartos। এরপরে এখান দিয়ে টেস্টিস নেমেছিল। নর্মালি টেস্টিস নেমেছিল। এই টেস্টিসটা কোথায় থাকতো? এক্সটার্নাল, সমস্ত আমাদের অর্গান পেরিটোনিয়াম পড়াবো, ইউজুয়ালি প্রেজেন্ট ইন দ্য ব্লাড ভেসেলস, ইউজুয়ালি প্রেজেন্ট ইন দিস লেয়ার। এটাকে আমরা খুব অবজ্ঞা করি, আমরা ভুলে যাই বলতে এক্সট্রা পেরিটোনিয়াল টিস্যু, কিন্তু অল অর্গানস, blood vessels not present within the peritoneal cavity. সেদিন বলেছিলাম, it is present outside the peritoneal cavity, having covering of the peritoneum only. It is present in the extraperitoneal tissue. Extraperitoneal tissue, loose areolar tissue with fat are present. তাহলে টেস্টিসটা ওখানে ছিল। টেস্টিস, এবার ফিটাসের টেস্টিস, when testis develop at about 8th month, it comes down at the scrotum, dragging a peritoneal fold along with it. Peritoneal fold এর নাম কি? What is the name? যে টেস্টিসে যখন নামছে পেরিটোনিয়াল ফোল্ড একটা নিয়ে নামছে কভারিং দ্য টেস্টিস, ও শুধু একাই বলছে কেন? প্রসেসাস ভ্যাজাইনালিস, খেয়াল রাখবে প্রসেসাস ভ্যাজাইনালিস। তোমাদের টেস্টিসের ডেভেলপমেন্ট প্রায় হয়ে যাচ্ছে, ডিসেন্ট অফ টেস্টিস। তাহলে এখান দিয়ে যখন নামছে, টেস্টিস এখানে ছিল, এখানে টেস্টিসটা ছিল, তাই তো? এই টেস্টিস এবার ডিপ রিং দিয়ে গিয়ে সুপারফিশিয়াল রিং দিয়ে নামবে, নামলো এইখানে টেস্টিস, and it drags, drag মানে কি টেনে নেমে a fold of peritoneum known as the processus vaginalis এখান দিয়ে গেল। processus vaginalis normally in fetal period, not you, not us. তারপরে যেই at the time of birth these processus vaginalis become obliterated, একটা thin string হয়ে যায়, এরকম হয়ে যায়। Only this part is present, only the distal part, this is the proximal part, this is the distal part, only the distal part is present, only the part of the processus vaginal is present in relation to the testis, others will disappear with a fine string, দেখাই যায় না। and this peritoneum, এই যে গ্যাপটা ছিল এটা আবার সিল্ড হয়ে যায়, তাহলে only this part is present, এবং এটার নাম হয় তখন, this name is changes tunica vaginalis, tunica vaginalis, it is present in me, present in all male, tunica vaginalis, right? এবার হার্নিয়া হচ্ছে, হার্নিয়ার আগেই বলেছি একটা গাট এক্সট্রা পেরিটোনিয়াল টিস্যুতে থাকছে, আচ্ছা কমপ্লিট হয়নি, and when it descends down it takes a covering of the external oblique aponeurosis, it takes a covering of the external oblique aponeurosis, we call it external spermatic fossa. It takes a covering of the internal and transversus abdominis, but this covering changes again into muscle, we call cremasteric muscle and fossa. And it also takes a covering of the fossa transversalis, we call internal spermatic fossa. Also it drags down whenever there is a hernia, normally this. Now তাহলে what are the coverings of the testis? এখান থেকে যদি বলো in the scrotum, skin, number 2 কেউ বলো dartos, number 3 external spermatic fossa, number 4 cremaster muscle and fossa, number 5 internal spermatic fossa. These are the coverings of the testis. আবার রিপিট করছি, ভালো করে দেখো, skin, dartos muscle, এটা এই কালার দিয়ে দিই, this is the external spermatic fossa, then dartos cremaster muscle, then the internal spermatic fossa. So these are the coverings of the testes. ভালো করে দেখলে এখানে আমি স্কিন আর ডার্টোসটা আঁকলাম না। এটা হচ্ছে এক্সটার্নাল অবলিক অ্যাপোনিউরোসিস মাসল, এক্সটার্নাল অবলিক, ইন্টারনাল অবলিক, এটা হচ্ছে ট্রান্সভার্সাস অ্যাবডোমিনিস, এটা হচ্ছে ফাসা ট্রান্সভার্সালিস, এটা এক্সট্রা পেরিটোনিয়াল টিস্যু, এটা হচ্ছে পেরিটোনিয়াম। তাহলে এটা হচ্ছে টেস্টিস। হোয়াট আর দ্য কভারিংস? এক্সটার্নাল স্পারমাটিক ফাসা, এইটা দুটো জয়েন করে গেল and gives a muscular covering which is called কি এটা? হ্যাঁ, ডার্টোস বাইরে আছে, এক্সটার্নাল এর বাইরে আছে, এটা কি? কি এটা? ইন্টারনাল অবলিক এন্ড ট্রান্সভার্সাস অ্যাবডোমিনিস, হ্যাঁ, ক্রিমেস্টার মাসল, ডার্টোস এর বাইরে আছে, স্কিনের এখানে আছে, এই যে স্কিন, এইখানে আছে ডার্টোস মাসল, এক্সট্রা পেরিটোনিয়াল টিস্যু গিভস এ ডার্টোস মাসল, এইখানে আছে ডার্টোস মাসল। তারপরে কে কভারিং দেবে? ফাসা ট্রান্সভার্সালিস। এটার নাম কি? এটার নাম কি? ফাসা ট্রান্সভার্সালিস যে কভারিং দেয় তার নাম কি? ইন্টারনাল স্পারমাটিক ফাসা। ইন্টারনাল স্পারমাটিক ফাসা কেমন? তারপরে আছে এক্সট্রা পেরিটোনিয়াল টিস্যু, এরম করে কভার করে আছে। আর এই হচ্ছে পেরিটোনিয়াম। তাহলে কভারিং অফ দ্য টেস্টিস কি? স্কিন, ডার্টোস মাসল, এক্সটার্নাল স্পারমাটিক ফাসা, ক্রিমেস্টাল মাসল এন্ড ফাসা, ইন্টারনাল স্পারমাটিক ফাসা, এক্সট্রা পেরিটোনিয়াল টিস্যু, ওটা বলি না আমরা। এরপরে আর এইটা হচ্ছে পেরিটোনিয়াম অ্যাডাল্ট কে, এরপরে হার্নিয়া হলো। কেমন? এই হার্নিয়া যখনই কামে একটা পেরিটোনিয়াম এর সাথে যায়, পুশ করে নিয়ে আসে, এইবারে একটা গার্ড এখানে ঢুকলো, এটা হচ্ছে হার্নিয়ার একটা জিআই ট্র্যাক্টের, ধরো ইন্টেস্টাইন, এটা যেহেতু ডিপ রিং দিয়ে হয়েছে, তাহলে এটা কি? হোয়াট টাইপ অফ হার্নিয়া? ডাইরেক্ট অর ইনডাইরেক্ট? ডিপ রিং দিয়ে ঢুকেছে, ইনডাইরেক্ট। সো হোয়াট আর দ্য কভারিংস অফ দ্য ইনডাইরেক্ট ইনগুনাল হার্নিয়া? এটা হচ্ছে হার্নিয়া, এটা হচ্ছে হার্নিয়া। সেম কভারিং লাইক দিস, স্কিন, ডার্টোস মাসল, এক্সটার্নাল স্পারমাটিক ফাসা, ক্রিমেস্টাল মাসল ফাসা, internal spermatic fascia and a pouch of peritoneum. These are the coverings of the indirect inguinal hernia. পরীক্ষায় লিখতে হবে। ডাইরেক্ট হার্নিয়া, ডাইরেক্ট হার্নিয়া এই জায়গাটা রয়েছে হেসেলব্যাক স্ট্র্যাঙ্গেল, এইখানে রয়েছে ইনফিরিয়র এপিগ্যাস্ট্রিক আর্টারি, এই যে ইনফিরিয়র এপিগ্যাস্ট্রিক আর্টারি, এটা হচ্ছে অবলিটারেটেড আম্বিলিকাল আর্টারি, এখান দিয়ে ইনফিরিয়র এপিগ্যাস্ট্রিক আর্টারি গেছে। ডাইরেক্ট হার্নিয়া দুটো টাইপ, ল্যাটারাল ডাইরেক্ট এন্ড মিডিয়াল ডাইরেক্ট। ভালো করে বোঝো, ল্যাটারাল ডাইরেক্ট এন্ড মিডিয়াল ডাইরেক্ট। ল্যাটারাল ডাইরেক্ট occurs in between the inferior epigastric artery and obliterated umbilical artery, and medial direct occurs between the medial to the obliterated umbilical artery. It is the inferior epigastric artery, it is the obliterated umbilical artery. তাহলে এইখানে যদি হার্নিয়া দেয় তাহলে কি কি কভারিং হবে? স্কিন, ডার্টোস মাসলটা তখনও থাকে, তাহলে কি কি কভারিং হচ্ছে? skin, superficial, dartos muscle, external spermatic fascia, premasteric muscle and fascia, কিন্তু এইখানটা রয়েছে, এই জায়গাটা ভালো করে শোনো, here there is a no, এই যে হোয়াইট মার্ক দিয়ে করলাম, ভালো করে বোঝো, there is a no internal spermatic fascia. Instead, it is again back to fascia transversalis. Internal fascia transversalis is only present in relation to the deep ring. Fascia transversalis is only present in relation to the deep ring. যেই এপাশটায় সরে আসছে, ভুল বললাম, ইন্টারনাল স্পারমাটিক ফাসা, ভুল বলেছি, আবার কারেক্ট করছি, ইন্টারনাল স্পারমাটিক ফাসা only present in relation to the deep ring only. সুতরাং internal spermatic fascia is a covering only in indirect hernia. মাথায় ঢুকে নাও, internal spermatic fascia is a covering of only indirect hernia, indirect inguinal hernia. And in direct hernia, internal spermatic fascia is replaced by its original thing, that is the fascia transversalis. তারপরে লেখো, this is the demarcation between the indirect and direct hernia in relation to its coverings. সব সমান, শুধু ইনডাইরেক্ট হার্নিয়ায় ইনারমোস্ট কভারিং হচ্ছে ইন্টারনাল স্পারমাটিক ফাসা, আর ডাইরেক্ট হার্নিয়ায় কভারিং হচ্ছে ফাসা ট্রান্সভার্সালিস। আমরা যখন খাতা দেখবো কিচ্ছু দেখবো না, শুধু দেখবো ডাইরেক্ট হার্নিয়ার কভারিং এ ফাসা ট্রান্সভার্সালিস লিখেছে কিনা, না ইন্টারনাল স্পারমাটিক ফাসা লিখে গেছে। যেই ফাসা ট্রান্সভার্স লিখবে 0, ওখানে 2 1 হয়ে গেল। তাহলে what is the difference between the wall or coverings of the indirect and direct? আবার বলছি, in indirect hernia, in internal spermatic fascia, which is derived from the fascia transversalis, is a covering of the indirect or oblique inguinal hernia. But in direct hernia, no internal spermatic fascia is the covering. It is covered by fascia transversalis, whether it is a lateral direct, whether it is a medial direct. So what is the coverings of the lateral direct hernia? পরপর বলো, মনে মনে বলো, skin, dartos muscle, external spermatic fascia, তারপরে premasteric muscle and fascia, তারপরে indirect fascia transversalis, fascia transversalis. In lateral direct, finished. In medial direct, এবার কেউ বুদ্ধি করে বলতে পারবে? In medial direct, there is another covering. দুটো আরো এডিশন আসবে। কি কি আসবে? ভেরি গুড, বাহ, শিখে গেছে। In medial direct, fascia transversalis এর আগে, before fascia transversalis এর পরে আসবে posterior wall, conjoint tendon and reflected part of the inguinal ligament. কারণ এইখানেই রয়েছে কনজয়েন্ট টেন্ডন, এই posterior wall এ conjoint tendon and reflected part of the inguinal ligament. তাহলে মিডিয়াল ডাইরেক্টেড কভারিং কি হচ্ছে? স্কিন, ডার্টোস মাসল, অথবা অনেক সময় আরো এইদিকে গেলে আর ডার্টোস থাকে না, তখন তার জায়গায় সুপারফিশিয়াল ফাসাই থাকে। তারপরে হচ্ছে এক্সটার্নাল স্পারমাটিক ফাসা, তারপরে হচ্ছে premasteric muscle and fascia, fascia transversalis, then conjoint tendon and reflected part of the inguinal ligament. উল্টো বললাম, এই ইন্টারনাল কি বললাম, premasteric muscle, conjoint reflected part, then the fascia transversalis হয়ে গেল। তাহলে এইটা হচ্ছে মিডিয়াল ডাইরেক্ট। এই কভারিংসটা অনেক সময় লিখতে দেয়, কেমন? তাহলে আমরা একটু ছবি দেখি। This is the coverings of the indirect inguinal hernia. কেন দেই? এবারে তোমাদের ফাইনালে এই লং কোশ্চেন দিতে পারে, ইনডাইরেক্ট হার্নিয়া ইংনাল রিজন থেকে লং কোশ্চেন গতবার দেয়নি। এই যে এখানটায় ডিফারেন্স, এটা ভেতর থেকে আসছি, ইনসাইড আউটওয়ার্ড, ইনসাইড থেকে আউট। আমি বলেছিলাম আউট থেকে ইন। এখানটায় আগেই বলেছি যত মিডিয়ালি যাচ্ছে অনেক ট্রিমেস্টার মাসেলও ডিসঅ্যাপিয়ার হয়ে যাচ্ছে, কারণ স্কটাম থেকে আরো মিডিয়ালি চলে যাচ্ছে। সুতরাং ট্রিমেস্টার মাসেল লিখলেও হবে, না লিখলেও হবে। এটা সবাই লিখে নাও, এটা খুব জিজ্ঞেস করে। ডাইরেক্ট ইঙ্গুনাল হার্নিয়া ডিফারেন্স বলেছিলাম। হোয়াট ইজ দ্য ডাইরেক্ট অ্যান্ড ইনডাইরেক্ট ইঙ্গুনাল হার্নিয়া? একটা অকার্স থ্রু দ্য ডিপ রিং, আর একটা অকার্স থ্রু দ্য ট্যাঙ্গেল অফ হ্যাসেলব্যাক। Usually occurs in young age, congenital, where the process of vaginalis is present. Direct hernia occurs in old age, where there is a weakness of the abdominal wall muscle. Number 3, indirect hernia is usually কি বলছিলাম আরেকটা, medial to the lateral to the inferior epigastric artery, and direct hernia is medial to the inferior neck of the hernial sac is lateral to the inferior epigastric artery is the indirect hernia. In direct hernia, neck of the hernial sac is medial to the gastric artery. এরপরে fourth point, এরপরে coverings। এই coverings এবার লিখতে হবে। In indirect hernia, coverings in ... In direct hernia ... তারপরে usually it is indirect hernia, direct hernia is reducible, it is sometimes non-reducible. This is the difference. ভালো করে পড়বে। What is the difference between inguinal hernia and femoral hernia? In the bedside, pubic tubercle. Pubic tubercle. In the bedside, you feel the pubic tubercle, and if the hernial sac is medial, ভালো করে শোনো, medial and above, it is a inguinal hernia. হ্যাঁ হ্যাঁ, So this is the pubic tubercle, and inguinal hernia occurs through this. This is the inguinal hernia, and femoral hernia occurs through this. So, inguinal hernia, neck of the inguinal hernia lies medial and above the pubic tubercle, and in neck of the femoral hernia lies below and lateral to the pubic tubercle. আমরা বেড সাইডে আমরা ইজিলি বুঝতে পারি। আমরা যদি ফিমোরাল রিংটাকে এরকম করে বন্ধ করে দেই, তাহলে ফিমোরাল রিডিউস করে ফিমোরাল হার্নিয়া বেরোবে না। কিন্তু ওটা জিজ্ঞেস করি না, আমরা জিজ্ঞেস করি হাউ টু ডিফারেন্সিয়েট বাই পিউবিক টিউবারকেল। দ্য নেক অফ দ্য ফিমোরাল হার্নিয়া ইজ অ্যাভাব, দেখতে পাচ্ছ, এটা যদি পিউবিক টিউবারকেল হয়, দ্য নেক ইজ অ্যাভাব অ্যান্ড মিডিয়াল, আর এটা যদি পিউবিক টিউবারকেল হয়, neck is below and lateral. So this is the main difference between the femoral hernia and the inguinal hernia. Look, this is the pubic tubercle, it is above and medial. This is the pubic tubercle, above, lateral and below. বুঝতে পেরেছো? ভালো করে না দেখলে কিন্তু বোঝা কঠিন, একই লাগবে। অত সহজ বললাম, বেডসাইডে অত সহজ নয়, অনেক কমপ্লিকেশন হয়ে আসে। আচ্ছা, রেকটাস অ্যাবডোমিনিস মাসল হয়ে গেছে। There is some clinical anatomy of the rectus sheath, divarication of the recti. There is a weakness in the linea alba, just in the epigastric region. So hernia occurs, abdominal hernia occurs in the epigastric region. We call the epigastric hernia. What is the clinical use or surgical use of the rectus sheath? Sometimes rectus cancer is very common, and sometimes extensive breast cancer, we have to sacrifice breast. Mastectomy. আমরা ব্রেস্টকে বাদ দিয়ে দিই, কেমন অথবা অনেকটা জায়গা ব্রেস্টের বাদ দিয়ে দিই বাই এক্সিশন, তখন বাজে লাগে। অনেক সময় সিলিকন গ্রাফট পাওয়া যায় আর্টিফিশিয়াল, সেটা করা হয়। আদারওয়াইজ অনেক সময় সিলিকন গ্রাফট অনেক সময় নেয় না, পেশেন্টের বডি নেয় না, অ্যাকসেপ্ট করে না। তখন আমরা কি করি, এই পার্ট অফ দ্য রেকটাস উইচ ইজ ব্লাড ভেসেল, এই জায়গাটায় আমরা ঘুরিয়ে লাগিয়ে দিই, ফলে এই জায়গাটা ঘুরিয়ে উঠলো, and it is known as a graft, medical graft use হয়। এইভাবে উল্টানো হচ্ছে রেকটাস, ব্রেস্টে নিয়ে যাওয়া। তাহলে বলবো উইকনেস হবে না, মাসল এক্সারসাইজ করতে হবে, মেনে নিতে হবে। This is the divarication of the rectum. Different abdominal surgical incision তোমাদের আছে। This is the medial incision. At the medial incision, there are different incision in our medial incision. Just lateral to the midline. Here we start the rectus sheath. Clearly, part the rectus sheath and retract the rectus laterally so that nerves are not injured. It is the best operation in laparotomy. What is laparotomy? যখন আমরা পেরিটোনিয়াম কেটে ভেতরে আমরা দেখতে চাই ভেতরে কোনো কি হয়েছে ধরতে পারছি না, তখন আমরা যে পেরিটোনিয়াম কেটে অ্যাবডোমেনে ঢুকি তাকে বলা হয় ল্যাপারোটমি। The base incision of laparotomy is the parametrial incision. আর কি হয়, বল ইনসিশনে আমরা এই ইনসিশন করি parallel to the costal arch, right costal arch. In gallbladder removal, transverse incision, or subcostal transverse incision. Sometimes we call Walker's incision. It is known as MBBS incision for appendicitis. And that kind of pelvic operation, stage operation. It will be common abdominal incision for the comprehensive urinary. And it is वे सोई कंप्लीट वेबसाइट पेरिटोनियम स्टार्ट हुआ है कल के पेरिटोनियम स्टार्ट हुआ अभी नॉट है साइज
And we learned about this particular bone, hip bone. So, fortunately and unfortunately, like 60% student failed to answer the parts of this bone. What this bone is composed of. So, what are the parts of this bone? Three parts. What are the three parts? Ilium, ischium, and pubis. Alright, the three parts. Now, out of these particular 40% student who identified these three parts fails to demonstrate which part is called which part. So, ilium, ischium, pubis. Which part is ilium? Which part is pubis? And which part is ischium? 20% of student out of the 40% student didn't mention or couldn't answer it properly. So, this part? Ilium. This part? This part? This opening? 70% of student fail to answer this forearm. It is covered by? Is covered by? Obturator membrane. Outside to the obturator membrane there is a muscle. Internal to it is a muscle. Obturator internus. And this opening? Acidabulum. It's an opening or it's a cavity? Cavity. So this acidabulum cavity is for lodgement of and forming a joint. What joint? Hip joint. A handful of students fail to answer this joint even. That's what I'm saying. Next time I'll be recording it. And it will be the evidence based. And I'll prepare the clips. I'll viral it. We are going to learn this particular region. We call them as pelvis. So this united bone, we call them as bony pelvis. What do you call them as? Bony pelvis. This is hip bone of the right side, left side, and fitted in between is the sacrum, which is making a joint, sacroiliac joint. So fitting together is making a bone, which is known as the bony pelvis. Now this bony pelvis, the thing which we are talking here, right? So the pelvic inlet, which is roughly here. This is a iliac crest which you see here, upper limit. So this is the greater pelvis, also known as false pelvis, which is basically continuation of the abdominal part or abdominal cavity. The blue line shaded here, between here, which is lying here between the pelvic inlet and the pelvic outlet, which is limited by this pelvic diaphragm. So in here, this particular cavity, which you see here, is a pelvic cavity, also known as the true pelvis. And below this particular true pelvis, which is limited by the pelvic outlet, which is covered by a diaphragm, which is known as pelvic diaphragm, we get this orange space below. This is known as perineum. So the perineum is approached from the external side to inside. So externally you see this perineum, then the pelvic cavity, then the abdominal cavity. If you are getting down from below, and above below is pelvic cavity, greater pelvis, false true pelvis, and then perineum. This is the way it is oriented. So this is again the sagittal section you see here. The pelvic rim and this particular pelvic cavity, abdominal cavity, which is continuous on this region. The pelvic beam is dividing this particular orange cavity with this blue cavity, which is limited by this particular diaphragm, which is known as the pelvic diaphragm. This particular pelvic diaphragm sits in a space, we call them as pelvic outlet, that region. And below that pelvic diaphragm, that region, we call this as the perineum, which is you see here shaded here or orange here. So this is how these cavities are oriented. And this pelvic beam, we talked about how to figure out the pelvic beam, the boundaries of it. And pelvic beam and this particular pelvic inlet are the same synonymous thing. Alright? Now, coming from here, the difference of the pelvic, true pelvis, false pelvis, and this particular pelvic inlet, that's a line we just talked about, right? So this is the grid line we started from here, right side to circulating back to the left side and fulfilling this particular thing. And this is the bony pelvis, that's what we started talking about. Now, this particular pelvis, bony pelvis coming from here, we're talking about the measurements whenever you measure. So this is what you are going to measure. If you are measuring it transversely, we call this transverse diameter. If you are measuring it obliquely, from the iliopubic eminence to the sacroiliac joint, we get another landmark line, which is known as oblique diameter. And again, you are measuring it from the front to back, we find this anterior posterior diameters. Anterior posterior diameters, you can measure it from the top side of the symphysis pubis, or the bottom side of the symphysis pubis, or in the back side middle point of the symphysis pubis to the midpoint over here, we call them as midpoint of the sacral promontory. Now, this measurement we are talking about, right? So, this particular measurement, whenever you are talking here, this matters to us. So, see that different lines are there, you just denote the different measurements. Oblique line, transverse line, and the anteroposterior line. Now, this anteroposterior line, which is the point of concern for us, whenever you are measuring this anteroposterior line. Now look at this particular picture, which is at the bottom end of this image. Now we see that one side of this pelvic cavity we are seeing here, the one hip bone with the sacrum you are seeing and looking on the sides. Now this is the three measurement line we are talking about. So one measurement you are making it with the black line above this symphysis pubis to the midpoint of the sacral promontory, the black line if you trace it. So you find a diameter. A diameter we call them as conjugates. Now this conjugate we call them as anatomical conjugates. So above the symphysis pubis to sacral promontory, we made the measurements. We get the line or the diameter, transverse diameter, we call them as conjugate. We call them as anatomical conjugates. Going back the bottom side, we find a green line. The lowest point of the symphysis pubis, the bottom side, to the midpoint of the sacral promontory. The green line we are seeing here. We call them as diagonal conjugates, the green line which you measure here. And this is the middle point of the symphysis pubis, which is the red line which you are seeing here. That's another line. We call them as obstetric conjugate, also known as true conjugate. Now, out of these three lines, we agreed the middle point of the symphysis pubis, the red line, is the least diameter. So that least diameter has to be more than 9 centimeter to allow the passage of the fetus through the birth tract, through the normal labor process or the normal vaginal labor. Because we know that 9 centimeter or 9.5 centimeter is this transverse diameter of this biparatal head diameter. So it has to be more than 9.5 to become this. So these conjugates or anterior-posterior conjugates, are we clear about or not? Which is what we have to memorize this basic thing. We are not emphasizing the diameters which is other than the anteroposterior at this point. Above, below and the middle. Three of these diameters and how we are measuring. Now, out of these three diameters, through clinical examination to a subject, we can measure this diameter. We call them as digital pelvimetry. It's not the digital thing, the E thing. It is digital means finger. We call them as per vaginal examination. So whenever you are examining a expecting mother, we try to assess the roominess of this pelvic diameter. So we pass the finger through the vagina and try to touch this particular sacral promontory, the midpoint, through the fingers. We call them as digital pelvimetry. So this is what we call them as digital pelvic examination. So through this vaginal tract, we try to reach this. So this particular point measurement, what you are measuring here is the lowest diameter or this particular lowest line, which is a green line. So this green line you are measuring clinical, through the clinical examination. Now whenever you are measuring this line, this can be measured. So if you get this line, say for example this line which you are measuring, this dotted line, this conjugate which you are measuring here is this one which is known as diagonal conjugate. So if you're getting this diagonal conjugate, that's not enough to assess this. We have to get this green line. So if you get this green line by doing the clinical examination, we subtract 1.25 centimeter from that line. So if you're getting it, this measurement is green line, if you're measuring it through digital examination, 12. So we subtract 1.25 to 1.5 centimeter from that line. So if you're getting 12, then subtracting it 1.25 to 1.5 centimeter roughly gives this diameter, which is the red line, which is the actual line of the fetal passage, which that fetus will be getting. So if it is more than 9.5, we are letting it happen. If it is not getting 9.5, then we go for cesarean section. This is the concept. This is the understanding. So this measurement plays a clinical role. Knowing this, if you are letting this particular birth tract to go for a bigger size, bigger head size fetus, then there will be significant injuries to the brain of the fetus. To avoid that, the prior examination is important. Before that, we didn't have this particular radiological interventions very much. Now we have the MRI scans, now we have ultrasounds. We can get this particular measurement by doing this particular ultrasound scan as well. So we can get it digitally with this technology, and as well as whenever you do not have this particular opportunity, then we have to go for this particular indexing finger or this measurement of this, and then we subtract this and get the rough thing about this measurement. So we take this, we get the skin marker pencils, we mark it where actually it is ending, so we mark it over here and then mark it here, take the finger out, then measure it with these fingers. So this is the middle finger which is touching here. From middle finger to this particular length, we are measuring it and subtracting it. We are getting this particular line, which is the point of concern for us, is this red line, which is the true conjugate or obstetric conjugate. Obstetric means that's the point we are letting this particular birth tract process to go or out. Clear? So 9.5 is the catch about getting through this particular different landmarks on this. And the objectivity of this is this point. So 1.5 is subtracting it by the diagonal conjugate, we get this particular obstetric conjugate. And obstetric conjugate is also known as true conjugate. And conjugate is nothing but the diameters whenever you take it. Alright? So this is about this particular anatomical landmarks and the diameters of this entities which you are making. Good? Okay? লাগে এখন আমাদের দরকার নেই ট্রান্সভার্স ডায়ামিটার আমাদের যে পারপাসে লাগে আন্ডারগ্রাজুয়েটে সেটার জন্য না যখন আমরা অবস্টেটিক্সে যাব ট্রান্সভার্স ডায়ামিটার একটা রুল আছে ট্রান্সভার্স ডায়ামিটার মেজারমেন্ট করার দুটো জায়গা রয়েছে একটা পেলভিক প্রিমিয়াম একটা পেলভিক আউটলাইন so that will be complex I'm not going to make these things complex as right now simple জিনিস এইটুকু আমরা আগে বুঝি all right good the diameters বোঝা গেল সিগনিফিকেন্স কি কেন জানতে কি ইম্পর্টেন্স alright so because forceps delivery meatus delivery পুরো কোর্সে কমপ্লিকেশন যখন তুমি অবস্টেটিক ক্লাসে যাবে তখন ওটা ঠিক আছে এখন থেকে ওদের আটকে গেলে বেশি আটকে যাবে এইটুকু আমরা ডায়ামিটার ঠিক আছে